Hey, welcome back to Eye on a Business. I'm your host, Dr. Steve Vargo, and today we're going to talk about a topic that's central to modern eye care, and that would be retinal imaging. But for many practices, this technology is still underutilized or seen just as another screening tool. So, our guest today is going to talk with us about how this technology is much more than just a retinal photo, how he's using it in his practice to improve patient education, boosting compliance, and even increasing revenue. And it's always great when we can combine enhanced clinical care with enhanced financial returns. So, welcome to the show, Dr. James Wood.
Thanks for having me, Steve. Appreciate the invitation. And you're exactly right. One of the things I really like about iDoc is there's always a really nice combination of CE and practice management. So hopefully you and I will try to follow that theme tonight.
Yeah, and not everything we talk about here is clinical based, but this
Yeah.
is a tool I even remember from my own days in practice. One of the clinical tools that really lended itself to a higher financial performance for a variety of reasons. I think we're going to get into it, and maybe we'll just start there. What do you wish more doctors understood about retinal photos? I think sometimes we look at it like something we can bill medically. A lot of offices might use it as a screening tool, but it's a lot more than that. So maybe just give an overview of what that means to your practice, and then we'll dig in a little deeper from there.
Okay. So I would encourage docs to look at wide field imaging as sort of a multifaceted, multi-dimensional tool that can help what we just mentioned financially as well as clinically. And I'm looking forward to digging deeper in both of those pillars, but it's tremendous on both counts, financially and practice management.
I know we're going to talk about wide field imaging. That's obviously that's a relevant topic as we're discussing this. And it's been described as you described it actually in the last time we talked. It's more than just a screening tool. So, could you explain a bit how it enhances the overall patient experience? And again, I think sometimes we look at clinical tools just from a clinical standpoint. What kind of data can I get from this? But
Mm.
there's a tremendous facet of this too that really enhances the patient experience.
That it's true. And that also is multifaceted. But I think it's important to realize that all these wide field and ultra wide field instruments for all the companies were brought on board as non-mid technology. So if we use that as the launching point, patients really appreciate when they can see when they're in the office, and they really appreciate when they can see as they leave the office, because they want to go back to work and be productive. They want to hit the golf course or play pickleball and not be all blinded. And perhaps most importantly, they want to look at their cell phone. And so it really does enhance the patient experience. I'm a little surprised, even though wide field imaging is widespread, it's mainstream, the number of new patients to our practice that have not had it. So we try to take advantage of that as our moment to shine. And we really dig into some educational things because this is brand new to them. And we therefore have the chance to really educate them that we're doing more than just testing their eyesight, but we're performing an overall total eye health exam with multiple implications.
Jim, can you speak to the patient reaction in your practice? Because I found just retinal photos in general, even older versions of this, older generations, to be the tool that had the biggest wow factor for patients. A lot of things they just don't understand. We sit there and we explain an OCT to them, and they're nodding their head up and down, just like you are now. But we really don't know. Do you understand what I'm talking about? Because a lot of times they're just afraid to ask, or they just figure, well, you know what you're talking about. But a retinal photo really makes a statement, from a visual standpoint, and it really gets people to go, wow. The wide field imaging, retinal photography, what kind of impact have you felt in your practice with maybe the feedback you've gotten from patients that that you might not get from some of the other technology?
Yeah, so it is unique, even though it's widespread and mainstream. In our area, it seems like it's unique. And so patients, as you said, when they see this for the first time, they really are pretty jazzed about it. I try to be big on patient education. And so when we're going over the retinal photos together, the retinal images together, I sort of channel my inner Bill Nye the Science Guy. So it doesn't take too much for me to get a little bit excited and try to share that enthusiasm with the patient. So they're kind of jazzed about this new technology, and I try to leapfrog on top of that. Go over the important landmarks, emphasize anything that we need to be concerned about, and therefore have to have them come back, either for more in-depth medical testing or a more frequent recall.
You mentioned comeback, you mentioned recall. I want to ask you about that as well, because that's something we struggle with a lot is getting people to come back on a timely basis. Usually more with the wellness exams, the annual exams. They seem important to us, the 12-month calendar year, but to a patient who's not really experiencing any problems and they're seeing good out of their glasses and they've still got 3 months of contacts left, it just doesn't seem quite as important to them to come back on the schedule that we've set for them. So what I tried to do to encourage a lot of doctors to, when appropriate, when there's something there, is give them a reason to come back beyond it's been 12 months. And we see things all the time. I don't think we communicate very well to the patient how important it is that we see them back for that. Because when they get that text message or that email 12 months later, I don't want their thought to be, I'm seeing fine. I'll go back when I need to go back. I want their thought to be, oh, the doctor mentioned something on the back of my eye he wanted to look at, or the dry eyes she wanted to follow up with, whatever the case is. But it's sort of a long-winded way of getting around to how has this technology helped with compliance in your office?
Yes. So back to how education is so key, and it's no better way to educate the patient than when they can see their own scans in real time. We don't have to wait a week for the results. It's right there in front of them. So they can appreciate what's going on. Even as a layman, they can kind of sort of understand now that they have the scan right in front of them. If there's an area of concern, we point it out. Oftentimes to try to emphasize that and imprint it, we use iPads for our EHI, so I'll take a picture of the wide field imaging. So it kind of imprints the patient, oh, this is really significant. He's taking a picture of this thing. And therefore, as you were indicating, when we have a tangible medical reason why they should come back, they're educated, they're more compliant, they're more likely to come back versus that semi-arbitrary 1 year, and yeah, I'm seeing fine, my eyes feel fine, I don't know. Yeah. Comparing that to a medical reason, they might in the back of their mind remember, oh yeah, he wanted to look at that spot. We got to monitor that. Or he said my nerves were kind of suspicious. So all those kind of things will resonate much more than just waiting for them to break their glasses. Or I love the one they can't come back because they're not eligible for their vision benefits. So having a medical diagnosis clearly has a higher priority than just sort of the whims of a vision care plan or the patient, like you were saying, I've got enough contacts, I'll put it off.
I know the answer to this, but I think it's still somewhat debated in terms of the peripheral retina and getting a wider view of that. Can you talk to that from a clinical standpoint? And I'm also curious where you stand, and maybe you can help put an end to the ongoing debate of do we need to dilate every year? That seems to be a debate that doctors fight about endlessly on. I see it on some of the social media. Oh, we need to, you can't trust the technology. You need to dilate, but the technology's gotten a lot better. So what's going on in the periphery? And do we need to dilate every year? What is the current thinking on that?
Ooh, well, I probably should deflect part of that because neither you or I have a JD after our name, Steve. So we're not
I'm
going
going to
to get
get you.
medical
So you're
legal
saying
advice.
don't get me in trouble because
Yeah, thank you very much. Thank you very much.
full disclaimer, we do not have a JD. So
Yeah,
your
but
not written in stone, but just what is the current thinking? Let me take you off the hook here. And has it switched at all to doctors getting more comfortable with not necessarily having to dilate every year, or is that still something that a lot of doctors feel necessary? And I know there's a range, there's an in between there.
yeah. And I'll first say that I'm coming at it from a private practitioner. So our friends and colleagues in other settings, referral centers, academia, VA centers, they may have a different understanding of wide field imaging, which is perfectly fine and very understandable. But for those of us that are in the trenches, like I believe most of your audience is, wide field imaging can make a tremendous impact clinically and for office flow. So why does it matter? Well, number one, wide field means that we get out beyond the posterior pole to the equator, literally the halfway point of the eye. And that's where the vortex veins are, of course. So it's pretty impressive that most of these machines can do wide field imaging compared to some of the legacy machines that are more posterior pole. And then ultra wide field means that it goes even further beyond the equator. And that's completely impressive in my book. So I am oftentimes very impressed, and I must say I'm usually satisfied with the images that we get. And that's the key. Are we satisfied with the images that we're getting? Are they wide enough? Are they clear enough? If not, then yeah, we have a job to do. But for a lot of us in the trenches, I think we find that, yeah, we really get really far out there. And so the importance of getting out there is probably threefold. One is just from a standpoint of thorough documentation, even the things that are innocent, the nevi, chirpy, white without pressure, cobblestoning, those kind of things, they're not likely going to amount to much, but it sure is good that we captured it and we have it in our documentation. We know it's out there, or we know that something isn't out there for future reference. Secondly, I think most of us are more concerned, obviously, about sight-threatening conditions. We probably all get a little concerned about tumors, tears, and detachments, obvious reasons. But there's other things that can apply. Posterior uveitis, different vascular conditions, RP, all sorts of things that it behooves us to see the peripheral retina from an ocular standpoint. And then thirdly, we think about systemic implications, things like sickle cell, STDs, various cancers, lupus, histo, and diabetic retinopathy. There's some studies that have shown that when we see dot and blots first in the periphery, that's a more ominous sign than when we see it in the posterior pole. So all kinds of implications, thorough documentation, discovering sight-threatening conditions, because we know a lot of conditions are asymptomatic, and then the conditions that have systemic implications.
You mentioned something in the email exchange that we had before we recorded this about capturing better image quality. I thought that was interesting. Is that a sort of trick of the trade there, something you've done for a while? Because I know that's an issue. Sometimes you look at something and say, is this artifact? This is blurry. Am I looking at what I think I'm looking at? And for those who are maybe new to wide field, to Optos, is there something you're doing that you've figured out a way to capture better images?
Well, I'll offer a few tips. And so we've been fortunate to be involved with wide field imaging since 2004. So I guess you could say we were early adopters of the technology. And of course, we've seen it change over time. I'm smiling because the original machine took up half the exam room. And for the time that it was, the images were pretty impressive. But fast forward now, and all the machines are tabletop mounted, and the images are sharper, wider, and truer. There's not that distortion like we used to have. So now that we have these really neat images, we want to make sure that we get the wide, clear view that we want. So one of the stumbling blocks oftentimes is the lids are in the way, these artifacts like you mentioned. So we have the patient in a darkened room just to let the pupil naturally dilate a little bit. If their lids are slightly low, we can use a cotton tip applicator right up against the crease, troll it inwards, and that gently lifts the lids out of the way. There's a couple drops that I think are underutilized when we think about wide field imaging. One of them is Upneek. We use Upneek all the time for the cosmetic as well as the functional benefits. Patients see more when the lids are elevated, more light comes in, they see more of the world. That's great. When it comes to screening and taking these tests, those pesky lids we can lift because for most people, Upneek will work in about 10 or 15 minutes and we'll get that elevation, and that can minimize some of that inferior blockage of the artifact. So what we can also do lid taping, and that's valid because unlike a visual field, the wide field imaging goes pretty quickly, and patients can handle having their lids taped up for just a few minutes. What we don't recommend is using toothpicks. We just have not found any traction from a practice management standpoint putting toothpicks in their eyes. So don't try that one at home, Steve. What has been very, very helpful, though, is eye steering. So wide field imaging means we want to get wide. If for whatever reason we don't, then we have the patient do eye steering. They look left, right, up, down. The computer stitches all that together in a mosaic. So we go from a narrowish view to the wide field that we want in the first place. That can be tremendously helpful. We also want to make sure that patients don't drift back as they are inclined to do. They flash and they want to blank and go back. So we encourage the staff to have them make sure they hold in their 1, 2, 3 after the flash, then they can relax and go back. That helps with capturing the widest images possible. Now, let's say we've done everything we can, but their pupils are just too small, and some people are just tough to get to. They don't necessarily have to be those young ladies with the wonderful false eyelashes. The lids are way out there with the lashes that can block things, but they might have small pupils or misplaced pupils. So 2.5% phenylephrine can be tremendously beneficial, because when we're thinking about wide field imaging, we don't need a 7 millimeter pupil. We just need to get it a millimeter or two bigger, and then we get the wide images that we want. 2.5% phenylephrine does that really well, and it doesn't ruin their day. It's not going to have the effects of cycloplegia. So those are a couple tips that might be helpful for practices that are newish to it.
Okay, no toothpicks, duly
No
noted.
toothpicks.
No toothpicks, but great advice, great feedback there for staff training. If you're listening to this,
Yes.
I think maybe jotting some of those things down, because obviously most doctors are going to be delegating this. So, but some really good
Yeah.
tips there for training the staff. Jim, can you speak to the financials? Not specific numbers, but what does this look like for a practice? It's all this stuff's expensive. And you're looking at the return on investment. So maybe just some general feedback on the kind of ROI that you might expect from this technology.
Yeah, they're not giving these instruments away, nor should they. They're very sophisticated, and it is a significant investment. That's, I think, the key to look at. Not some big expense, but an investment. Because even though most of us charge fairly modest fees for screening, when we capture a significant amount of our patients, that modest screening really builds up at the end of the year. And so it's not really that hard to easily off pay whatever the monthly rental, or just pay the thing off just on screening alone. And if you'd like, we can talk about some other things or later down the road. But once we capture something with screening, that opens the door to return for medical billing. So we've cast that wide net, we've found something. Now we go back with medical billing. That opens up that whole avenue, OCT, fundus photos, visual fields, whatever it might be, that we might not have had the opportunity to had we not cast the wide net in the first place.
Yeah, it's something that I think most doctors really appreciate about this technology is the ability to cast that wide net and offer this as a screening, which a lot of patients will opt into. But then the sort of dual ability, obviously within the guidelines of coding and not on the same day, but to have people come back for medical billing. But that's not even considering just back to the wow factor, and that component of it that really gets people to say, wow, this is really impressive. I want to come back to you because maybe my last doctor didn't have something with this, but also just driving that compliance, like we talked about before. Not every patient's jazzed up to come back in 12 months. But again, if you found something there, you found a nevus, you found something interesting in the back of the eye, you can show it to them. They're going to remember the picture a lot more than they're going to remember what you say. The data on people forgetting what doctors tell them within 24 hours is actually
Yeah,
scary, but
yeah,
people remember
yeah.
images and pictures. And again,
Right,
that's what I want them remembering in
right.
12 months, saying, oh yeah, Dr. Wood showed me the picture of that thing in my eye and he wanted to look at it in a year. That's
Yes,
going to hopefully motivate somebody to come back.
yes,
Um,
absolutely. And you're 100% correct. They are wowed, they are impressed. It is a differentiator, and it certainly helps with compliance and recall. So There's also some, I guess, soft attributes that are maybe hard to financially put pulse on, but things like documentation. I mean, it's near and dear to our hearts, but it's wonderful to have that image, that digital image in their permanent record. And we can go back later and make any annotations that we want to. I really appreciate that I don't feel stressed. Oh, I've got to get everything done on the retinal right when the patient's there. I can look at it when I have time. I can look at it, heck, from home or the next day, make those annotations. And it's there for us together, the patient and I, when we see them going forward 6 months, year, 5 years. And you make a good point. People are definitely willing to pay a little modest fee, like most of us do, over and over, and they tell their friends and family. So it can be a real financial benefit just on screening and medical billing. And there's other things coming up, I know.
Jim, how do you present the screening option? Because again, this is an area where some doctors struggle in trying to get the acceptance rate up to where they'd like it to be. Is it some doctors find that just giving them a simple form to read and sign, other doctors might have their technician explain it to the patient, a bit more controversial, but some doctors even just make it mandatory. What have you found works best in your practice?
Yeah, so it really goes throughout the entire patient journey. So if we can take a couple minutes, let's go through the journey. Used to be on the phone where things started. Now, of course, it's on the internet. So we want our website to indicate that we have ultra wide field imaging and that it's part of what we expect. Then when the patient does make contact with us, email, phone, whatever, it's reinforced that yes, we'll be doing the exam and our ultra wide field imaging. So the patient keeps hearing this over and over. It's no surprise when they get to the front desk. A lot of us are using patient communication tools, software like Solution Reach, Weave. We push out all the intake forms, including, you mentioned a form, including the form, so that again, they have this ahead of time. It's in black and white. This is what ultra wide field imaging does. This is why it's important. This is what it costs. Sign here. We learned many years ago we had an optional form. And then when we shifted to what's called an opt-out form, our acceptance rate went up from about 65% to about 90%. So not having all these options, but the whole practice just goes with the vibe that this is what we expect. This is how we roll. So it's not this optional thing. Do it if you feel like it. It's part of your comprehensive exam. That's the vibe that we try to send out. Okay, so they've hopefully done their homework, done the forms, brought them in. If they didn't, they forgot to bring the forms, then they have to spend time filling them out, and then that form at the front desk. Now, there are some folks that they just have to see it visually. So at the front desk, we can have flip charts that shows this is what we see with ultra wide field imaging. This is what we see without. And we've even taken a page from David Letterman. We have a top 10 reasons why to have ultra wide field imaging. Patients kind of sort of get a kick out of that. But some people need to see it in writing. All right, so we're at the front desk. Hopefully it's all taken care of. Mentioned ahead of time, because the last thing we want is the guy hanging over the front desk for 5 minutes asking questions about should they do this extra test, blah, blah, blah. We don't want them calling their spouse. Hey, should I do this extra test? Man, did you do it? Everything hopefully is done ahead of time, but things fall through the cracks. So hopefully now they're going back to pre-test. And you mentioned about pre-testing. So that's a wonderful time for those patients that are still on the fence. The pre-tester has a key role to emphasize why it's so important. It's part of their annual exam. This is how much we see versus what we don't. Dr. Wood wants you to have that. So, okay, so that bumps up the acceptance a little bit more. And what I found really, really helpful is when I review the charts ahead of time, I'll write on our routing slip a specific reason why this person needs the test. And it could be a lot of things. It might be they have a high prescription, family history of RD, or macular degeneration, or glaucoma, pretty much anything. We shouldn't overlook that wide field imaging is awesome for posterior pole. So we can capture so much with this technology. And if there's that spot, like you said last time, we want to monitor it. So the pretester can say, well, Mrs. Jones, Dr. Wood wanted you to have this test because of XYZ. That's certainly going to hopefully increase the acceptance a little bit more. So we're making progress on this journey, but there's a few folks that still aren't quite on board. They're hazy on what this whole thing is. And so another thing that we've tried to do is we've combined screening tests, so more added value. In our office, we do the wide field imaging with a screening version of OCT. So we have the wide field plus the granular central portion, and we can pick up lots of important pathology. Now, we're almost there, Steve. We're now into the exam room. So we can show them a video about why it's important. And then we, of course, emphasize what we see on the screen with the patient and what we're going to follow up on a year from now. But there are those patients, they just have to hear it from the doctor. Say, is this thing really important? Yes, it's important. We want to have this done. So that pretty much makes the circuit. I know that took a couple minutes, but the point is it's all part of the entire journey, and it's all part of the entire staff being in step, speaking one voice, so to speak. Associate doctors, partners, everybody has the same mindset. And that's how we found to get a pretty high acceptance rate. Some offices do better than us, but that's what we found helpful.
Yeah, I appreciate you taking us through the journey part. I want to unpack a couple things because I think it's really some valuable things there that could drive acceptance. One was, I think, hearing it multiple times. There's a reason, if we just even look at marketing, that companies don't just
Yeah,
put a commercial out, run it once, and then stop
right.
running it.
Right.
And sometimes they'll run commercials multiple times during the same show. It's that repetitive exposure. So the more they're hearing it, and you found success in giving them the option to opt out versus opt in. A little bit of, is that correct?
Yeah, so they have to decline. Everything is set up, and it's almost like an assumed close. It's assuming that they're going to have this done, but it's informational, tells them what the fee is. There's no surprises, but it's a impression, it's a vibe that this is what we're going to do.
Hmm.
We don't strong arm people if they really don't want to or care to. They have to decline. What we found is there's three categories of patients that say no. One is they truly are financially in a tight spot. There are plenty of folks that they're a paycheck away from disaster. So we try to be sensitive to that. There's other folks that, despite all our education and repetition, they still just don't get it. Or maybe they didn't read the form, or maybe they were distracted by the kids, but they just don't get it. So they're like, nah, I don't want this thing. And there's the third category is the patient that thinks they know better. You kind of mentioned before, oh, my eyes feel fine, I see fine, I don't need this thing. So there are those categories that we can't get 100%. I know there's some offices that are right at or better than us and close to 100%, but we can live with that small minority, and that's the three categories we found it. Despite our best efforts, they say thanks but no thanks.
Yeah, I think everyone listening to this has seen those patients, all three categories. But I like the option of opting out, of creating the impression, not arming people, because I don't think that's the best approach, but creating the impression that this is part of the standard of care that we provide. And there's a little psychology there, and people don't like to
Yeah,
lose things. So opting out is harder for us to do than opting in. So I think it's a
yeah,
pretty good approach. And I like, again, to repeat this part, but the having heard this multiple times before they're getting to the technician, because where I see the offices that struggle the most, it's letting the is giving the technician all the responsibility for getting the acceptance. And what I found is the same thing I think a lot of other offices find as well, is that sometimes you get a technician who's really good with communicating that, but a lot of times you run into two issues. One is we would find that the technician can sometimes be a little reluctant to confidently communicate something or recommend something that was going to cost the patient money. That they weren't,
yeah.
heck, a lot of doctors aren't comfortable with that conversation, but yet we're
Oh,
putting it on
right.
the
Yes,
tech.
right,
Or
right.
they would get bogged down with the questions because they're hearing it from the first time from the technician, and there's a fee attached, and now the technician's got to answer 17 questions, and it slows down the entire office. So I
Yeah,
like your approach to bring it up through the journey.
exactly. It's so much more helpful to have it front loaded, patients on board. Then there's less of this traffic jam in the pre-testing room because the pretesters have a lot on their plate too. And I think I should have mentioned how the words we use with all this are critical. I think I heard you say the word picture earlier. So in our practice, we try not to use words like picture, camera, photo, because our college age daughter could get her picture taken with a camera at a photo booth at a kiosk at the mall. That's not the connotation we want. So instead, we prefer to use words like digital retinal imaging or diagnostic retinal programming. So that way, it gives much more emphasis, seems more important, and it is, and it really more accurately reflects the level of sophistication that these tests do. They're very sophisticated. So diagnostic retinal imaging or digital retinal scans are good ways to go to elevate that from, it's beyond just a little picture. It's very impressive, very diagnostic.
I
Oh,
agree, and
so
I will remove picture from my verbiage of no.
just
I agree. I'm glad you pointed that out. I agree completely.
yeah. And we want to always try to make it a positive thing. If we come across that it's out of pocket and it's extra fee and it's not covered by insurance, well, of course, the acceptance isn't going to be so hot. So we prefer to use the term copay. So, Mrs. Jones, your copay for the digital retinal imaging is X, and it's part of your comprehensive exam. We found that that goes over much better.
And then, Jim, we were talking about the financial aspects of this before, and sometimes there's these indirect benefits. But I believe when we had a pre-call a week or two ago, you and I were talking, and you mentioned sort of this indirect benefit of potentially having higher optical sales, which is something I don't think we always consider, but not being blurry out there where you're trying to look at glasses. That was an interesting point. Can you expand on that?
Yeah, so I know our opticians appreciate if they're trying to sell four, $500 glasses, whatever it is, that the patient can actually see what they look like when they're trying them on. And they can see those forms that they're trying to show them about their vision benefits. And here's the copay, and this is what it is for anti-reflection coating. And otherwise, like, yeah. So when they can see what they're doing, all those things, as far as back to compliance again, go up. So it helps tremendously on glasses, certainly with contact lenses, because there again, when they can see, they're enthusiastic. And there's no better time to capture those yearly sales that a lot of us are interested in when the patient's excited, they can see well, the comfort's good. Yeah, sign me up for a year's supply. They can see those rebate forms that we're trying to show them or any other smallish print about the discounts that we might have in office. And the other important thing about that is if we don't capture the patient yearly sale when they're there in the office, when they're excited, chances of them getting it go down each day when they have left the office. So no better time to present that when the patient is interested in actually getting a year's supply. If not, if they're unimpressed with how they see, they may not be interested in one pair, much less a year's supply. So strike while the iron is hot. And that helps us out tremendously with wide field imaging, optical and contact lenses.
I don't know if this data still holds true, but I read one time that when patients say they'll come back, that 25% of those patients don't return, and something like 50% of the ones that do return spend less money because they don't remember what all the recommendations were, and then it becomes just give me what my insurance covers. So it's a it's a great point. I think trying to make sure that we do our best to communicate with patients in the optical as well, and they want to see. It's a it seems like an obvious thing, but yeah, we send people blurry into the optical and say, here,
Yeah,
go buy an expensive pair of glasses that they can't even see, and
great.
that's probably a miss on our part. And well, Jim, I really appreciate your time. You mentioned something before about things coming, and I'm just curious if there's you look into your crystal ball here, and what does the future in this space look like? One thing that comes to my mind is something we're hearing a lot more and more about. And I don't know if you got any thoughts on this or other things, but AI and the implication that that's going to have on diagnostic technology.
Yes, so for sure. And remote testing and Virtual testing is here to stay. Some of us aren't thrilled about it, but it's here. It's only going to get more widespread. And to your point, it's only going to get more accurate when we overlay AI into that. So when we think about underserved populations nationally and globally, this is going to be really, really beneficial when we think about that whole access to care. Something else that has kind of been in the press, detecting Alzheimer's through the peripheral retina. And so we're going to discover more and more about that as time goes on. Then there's probably other neurosensory diseases that we don't know yet that will be captured by wide field imaging. I mentioned before about the footprint decreasing from the early days. I think we're going to see that shrink even more and more. And there's probably going to be some sort of handheld model. We have what they call multimodal instrumentation, ones that can do the wide field imaging and OCT or fluorescein angiography. So there'll probably be something else coming down the pike. We didn't even talk about autofluorescence. That's a wonderful clinical tool to help out. So the more multimodal imaging coming down the pike. And we should not forget just the demographics of our country. There's this so-called silver tsunami coming. All the baby boomers, their population is increasing 65 and over. And in about 5 to 10 years, the over 80 population is really going to expand. Surprising to me, the ranks of ophthalmology are going to be staying flat. And so the theory is that ophthalmologists are going to be overrun with cataracts and injections. In the face of this huge wave of seniors that are going to need everything, dry eye to peripheral retinal disease. So those of us that enjoy the vision and the medical aspects of eye care are primed to really have a golden opportunity ahead of us. So it may be one of those, there's an upcoming golden era up ahead, but either way, I think the future is very, very bright for those of us that combine vision and medical eye testing.
Yeah, I agree. Thanks so much for your time, Jim. It's some great points there on the silver tsunami and the trends. I think when we look at where do we want to be putting investment dollars in our practices,
Yeah,
looking at where are things going and where's the best, as you mentioned, opportunity. And when we look at the changing demographics, I think there's a wonderful opportunity for technology like this, Optos, wide field imaging, to capture that. There's a lot of shiny new toys out there, always
yeah,
coming our
yeah,
way, but sometimes we just sort of default back to the what are the standbys, but also things where the technology has improved significantly. We want to make sure that we're not overlooking those things either. So great stuff. I appreciate taking something that I think a lot of practices have. We've been doing retinal photos for a
yeah.
while, but really sort of taking it to the next level thinking. So, yeah, thanks again for your time.
Appreciate you having me, Steve. Thank you.
Well, thanks to Jim, and thanks everyone for listening. We will see you in the next episode.